So we're going to go start, and then we have a pointer as well. Sorry, sitting in the front here, easily accessible. Okay, let's start. So recently I've had taken Liam a little fishing. It's kind of fun. That's his first little bluegill that he caught, so he was very excited about it. His sons have moved on to helicopters and drones, so fishing is not quite up there anymore, but we still go a little bit. So first image that's up here, what do you see, and interpret the image a little bit.
Sure, so we're looking at ocular ultrasound, and
Okay.
pointer's working. There we go now.
Okay, ocular ultrasound, okay. So perfect, I'm going to start the video a little bit,
Sure.
and tell me the findings that you see here.
Looks like papillary edema, maybe.
Excellent. How would you why do you think there's papillary edema?
Because there's kind of bulging of this
Yeah.
optic disc.
Perfect, yeah. Perfect. Yeah, so typically we look for retinal detachments, we look for vitreous detachments, we look for vitreous hemorrhage. Those are the three common things we can see. This is a utility in ultrasound that you can actually look for papillary edema, indicate intracranial hypertension. Normally right here at the optic nerve sheath area, there's a little concavity here. But instead, you see a little convexity. Do you see that? A little bulging out. That indicates papillary edema. So what other measurement can you do on ocular ultrasound to determine what somebody's intracranial pressure is?
So, right, so you can look at the diameter of the optic nerve.
Okay, where would you measure that?
I don't know.
Okay, perfect. So let's go on to this case. So this is a 18-year-old patient, comes in with fever into the emergency room. She's altered. During the 20 minutes that she's walks in from triage to the back, she becomes unresponsive. She's brought into the A6, where she is is in the process of being intubated, and the question is, in our minds, should we get a CAT scan to see, or should we just proceed to lumbar puncture because she is very high risk for meningitis? So, what do you think this patient? Do you think you want to get a CAT scan? Is there clues on a quick look there that the patient has intracranial hypertension? Yes. So significant elevation in the intracranial pressure. This patient subsequently did have a CT. It was interpreted as no masses or anything. Patient was tapped. She had nice serial meningitis, and she herniated that evening and died the next day. So
her tap was pus.
her tap was pus.
What was her opening pressure?
I wasn't there for the lumbar puncture. Okay. So this alludes to where to measure for optic nerve sheath diameter. So you go at the back of the retina where you get a nice perpendicular shot of the optic nerve as it comes out. 3 millimeters back from the retina, you go from the outside diameter of the optic nerve, and you can see that her measurement is 65 millimeters, so 6.5 centimeters. So what is normal?
For adults, it's I think less than 5.
Less than 5, or it's probably less than 45 millimeters is probably the normal. When you use 5, you're going to be very sensitive. You're going to start picking up the abnormalities. And so
5 millimeters or 50 millimeters?
This is 0.6 centimeters. So it's 5 millimeters.
So 5 is normal? Sorry. You said 5 is normal?
Less than 5 is normal.
Less than 5 millimeters?
So you can see that measurement there is 0.3 centimeters. So that is.
So that's 65 millimeters, and normal is 5 millimeters?
6.5 centimeters would be 65 millimeters, right? So that's this 6 centimeters is 6 centimeters 2 inches, right?
Mm-hmm.
So just that's bigger than your eye. You know, we're looking at the nerve at the back. So this is 0.6 of a centimeter. So this is 6.5 millimeters.
Mm-hmm.
Yeah, correct. Does that make sense?
Okay.
So it's a millimeter reference that I reference, but the machine measures centimeters. Does that make sense?
So 0.5 centimeters is normal.
Less than that.
Less than that.
Is normal. Okay. Here is another case here. So actually, that's the is that the same one? Let's see. Okay, here's another case. So so same different. This is an 18-year-old patient. She comes in from clinic. She has visual changes, severe headache, has been scanned already. The scan is negative. She's on birth control. The primary care doctor appropriately think, what condition do they consider her? What condition would you consider an 18-year-old on birth control who comes in with a headache, negative CT with vision changes?
Oh, that'd be like
Yeah, intracranial hypertension. What does it mean? The intracranial, you should have increased intraocular pressure. How do you diagnose the visual change? You look for papilledema, right? We all pretty much suck at looking for papilledema. So I have a good way to look for it. So you see again that you clearly see at the back of the retina, you see a little bump. So it's very clear to see this. And so you can actually use this very well. So you look at this back of the eye, and you can see where you're normal, you see that normal flat retina in the back, you clearly see a big bump. And then we measured this one, and look at that, that is 0.7 centimeters. So almost double the normal size for 18-year-old.
So yeah, I think your measurement clarifies my question, but you go from not where the kind of the zero level, you actually go from the bump, 3 millimeters back.
Yes, correct.
Okay.
Yeah. And it's not going to be making that is just a nomenclature. It's not going to be making a difference there or there versus there. It's just to have a nice reference point. So you going Zach, I'm tapping this lady. What is essential when you want to tap this for this diagnosis? You have a headache. You don't think it's infectious. There's some vision changes. What's critical to do when you do this lumbar puncture?
Get the opening pressure.
Correct. You want to do the opening pressure. How would you do that? What is important in that?
You gotta have her sit straight up, or she had to sit up to get the opening pressure, right?
So that is the question. This is critical. So you're gonna measure that, and that's the question: is it a supine or a sitting up position?
Sitting up. I guess a lot of people say sitting up, but I've also heard the other argument that it really
So just think about it as all other measurements that we do. If we take somebody's blood pressure, we want it at the level of the heart, correct? We want CBP, you want that level. It's in reference to the central area.
Yeah.
So the nomenclature for that is laying straight.
laying down. I'm sorry.
The other caveat with that too is if you are tensed up and in agony and pain and the maneuver is uncomfortable and you Valsalva down, that thing is going to go a little bit up. It's probably not going to cause a 50 centimeter of water pressure, but it will probably go above the threshold of 25 to 30, so it's going to be confusing. So these patients need to be really relaxed, calm, cooperative in lateral decubitus position to do that. And then I'm not always sure if this is a good case to use the atraumatic needle, because I wonder if there's opening pressure studies that have been done through flow through a normal cutting needle. So I'm not sure. In this case, I would just, the chances of getting a post-procedural headache from a CSF leak that causes less fluid around the brain, or somebody that produces a lot of fluid, is probably not valid, So.
What's the latest, about straightening the legs or not? When you're getting the opening pressure, there's talk about if they're curled up versus straightening the legs.
Most of the time to get the axis, you want that position a little bit. So I just make sure that they seem relaxed. Their abdominal walls not tightened, and then if the value comes close to the 25 value or so forth, straighten the legs and see if it dips down a little bit. But in this case, the opening pressure, what do you think this opening pressure is going to be with this optic nerve sheath diameter? Guess? So hers dropped over the 56 marker, started to go over. So right all the way to the top and start to go over. So then when you do that LP, the other thing is give them some symptomatic relief. The treatment is to get some fluids off. So don't get your 1 cc's in each tube. Take some fluid off. They're going to feel significantly better.
Just a related question, did you have to get a head CT scan before doing LT?
The CT was done in the outpatient setting. I think most of us probably, somebody comes in with a debilitating headache, it's been ongoing. They have some vision changes. Most of us will get a CT first.
And certainly in this case, right? I mean, you see signs of increased ICP.
Yes.
You want to make sure that it's not, tumor cerebrae and not pseudo cerebrae.
And this also points out the difference in when you have a pericardial effusion. You can have a huge, sorry Billy, I'll get to it, a huge pericardial effusion that doesn't cause tamponade. Then you get a moderate pericardial effusion that causes tamponade. Same. The first patient has an ICP elevation and she dies from herniation. This patient's ICP is much more higher. We took up much more fluid and she didn't herniate. So there's a little bit of a gray area in between that, and there's probably some medical myths that Matt will eventually cover too. That is the patient just so sick from the meningitis they would have, and you give them antibiotics and they're so swelling, if you tap them or not, they would have died. So. Billy.
Just a question for the group. I've heard some people say that if you're hard pressed, you can tap them sitting up and move them once you get the tap and measure the pressure. I don't know what people feel.
That's certainly the case. Every one of us has a comfort measure. I would think that that's like central lines. You should not always just go for the right IJ with the ultrasound. You should involve your skills. When you intubate somebody, you should be having other skills than just the MAC4. The same with the LP, because to make this diagnosis, it's best to be supine, so you should be able to do an LP sitting up and supine. And it should not be just one technique, otherwise, because transfer the position, patient is always difficult, they can dislodge it.
Can you use that new hockey stick probe when you're doing this, or do you still recommend just a linear?
So the hockey stick probe, the linear probe is totally sufficient to that. You can use the hockey stick probes much more higher frequency, but I do see a little bit more artifacts with the hockey stick probe. Its frequency is so high. Last night we had a patient with flashes in the eye, and that patient had a lens implant. And that high frequency probe just made lots of artifactual images come down to think, whoa, is there something back there? We switched to this probe and it's clearly not there. So. Okay, this is an incorrect measurement. You can see you're not perpendicular to the nerve. We're not 3 millimeters back from the retina. So somebody submitted this as a normal optic nerve sheet diameter. But you should see the optic nerve sheet come all the way to the retina to be perpendicular to that. You want to be 3 millimeters back and go all the way from side to side. So this would be an incorrect measurement.
The positioning then of the eye to get it. I've had some of that problem trying to get the nerve sheet perpendicular.
So the nerve comes in at an angle towards the eye. So it goes in this. So if you're on a particular eye, you want to turn outside towards the probe, and that will get the probe axis in the line of the axis. So just have the patient tilt slightly to the right to get that axis of as the nerve enters the eye. Okay, so I'm just going to run through this study. This is a very cool images too. So this is a patient, and I submit this because it's the only image of Dr. Kohler I have for the last 6 months.
You're welcome.
So this is a patient with liver cirrhosis, and I want to just point out to you, you can see the very cirrhotic liver, but I want to point out the gallbladder because this is a common caveat or pull. You can see the gallbladder wall is thickened. So there's conditions that thicken the gallbladder wall, and that does not mean cholecystitis. Right, acute HIV infection can do it, liver cirrhosis can do it, acute hepatitis B, C, those can all do it. Nephrotic syndrome can do it, severe right-sided heart failure can do it. So the fact that somebody has, and heart failure is often a difficult one because they have a little bit of backflow into the liver, so the liver gets a little bit congested, a little tender. You can look over the right upper corner area, see a huge gallbladder with a thick wall without stones, and then, that is a little pitfall that you have to be aware of. Those conditions do cause gallbladder wall thickening. You see that? A gallbladder looks thickened on the side, but it's not abnormal. And nice cystitis that you can see here as well. So here's a nice image for Dr. Mal. I just want to illustrate that he captured here. So a cystitis patient that he evaluated for spontaneous bacterial peritonitis, and you can see under the ultrasound guidance, he put a nice needle safely into the pocket of fluid and able to get the fluid off. So use the ultrasound dynamically. You're in the fluid. You can see if you took all the fluid off. You can make sure the tip of the needle is not clear to any omental or liver or other structures. Okay, who's up next? So, where are we right now?
So I think we see a liver on the.
Do you point up? Do you have the pointer? Perfect. Yeah. See the liver. Yeah.
A little bit of kidneys.
Yep.
Bowel gas that's
I agree.
covering up some.
Okay, so we're in the right upper quadrant area. So it's a typical where we look for fast views. This is where you're going to look at the IVC. This is where you're going to look for pleural fusions when you go above the diaphragm a little bit. But this is your right upper quadrant classical fast view. So this, put your picture a little bit. So this is a 15-year-old who female, comes in with significant abdominal pain. Started abruptly, acutely. She's very uncomfortable. And so you get this image in the right upper quadrant area. What do you see?
So you see some free fluid between
Yeah. Does everybody see the stripe of free fluid there? It's subtle, but it's there. Does everybody see it? Anybody have difficulty with it? So liver, kidney, rib shadow right there, and you see the little stripe of fluid up there. Does everybody appreciate it? Yeah. So what 16-year-old female, free fluid in the right upper quadrant area, what's the first thing you want to know?
Is she pregnant?
Okay, perfect. Not pregnant. So what can this be then?
Ruptured appendicitis.
Could be a ruptured appendicitis. There's a case here, we're not going to review it, that Gessen did, great case, subtle fluid there, found the complex mass in the right lower quadrant area was a ruptured appendix. So it could be pus, could be blood. What's that? Ruptured cyst, right? Ruptured ovarian cyst. Yeah, could be that. So if you want to look into the adnexal structure, so here is her right adnexa. So bladder sits over here, hip bone sits over here. So this is a structure in the right adnexa. So what do you think? So what do you think that is?
Cyst right here.
Yeah. So this whole screen is 12 centimeters. So this is about 10 by 8 centimeter. And actually, this whole thing, this entire thing, is a structure in the right adnexa. So what do you think that is?
Ovary.
Yeah, it's ovary. And so you see maybe some normal ovary tissue here, but very mixed echogenicity. You see a little bit of higher acoustic shadows or shadow. So what kind of ovarian probe gives you a mixed picture with all kinds of different products in there?
Or teratoma.
Yes, perfect, yeah. So if you see this now, so you have a little bit of free fluid, 16-year-old in severe agonizing pain, and they have this adnexal mass that probably a dermoid teratoma. What do they have? What happened to them? Why are they in pain? Why are they in the emergency room? They've had this dermoid tumor probably for 6 months. Why are they today? Why are they in front of you now?
Did you put some Doppler on it? I know.
Perfect.
They're torsing.
They torsion, yeah. So no flow here. She went I immediately took her to the ultrasound suite, and as soon as the tech said yes, no flow, OB, and as soon as she got back to the back into F9, the OB was waiting right there, took her to the OR.
So
Okay.
could you, could we have done the flow, without even sending her down?
Yeah, you can. The Zonari has difficulty with flow. It's one of the pitfalls of the Zonari. It's low flow states, it's not very accurate. I think testicle torsion or ovarian torsions are difficult diagnosis because they are intermittent. So I don't think it is one of those bottom fruit diagnoses that we should pick and put yourself in that liability with a machine that has variable accuracy on Doppler and a condition that intermittently occurs. I think the combination of those two are not where I would pick bottom fruit at.
But somebody that has a lot of pain and has an ovary, I think, larger than 5, or any
Yes.
mass larger than 5, that's kind of the magic number. That's
Yeah.
where you start to get, high probability of torsion.
Yeah.
So you should just get OB on board like you did
Yeah.
while you're sending them to the
Yeah.
So
That's 5 longitudinal or transverse? Or anywhere.
Well, it's going to be a dimension. Usually, most cysts are large, symmetrical, so it's 5 by 5. But most cysts have almost close measurements, but it's a 5 measurement somewhere, right? Where you
Anything
start.
bigger than 5
Correct.
on the.
Does that make sense?
Yeah, so why did she have free fluids? I mean, is that common in her?
Well, she caused some inflammation. There was some free fluid up there. I'm not sure. Most of the time when I see acute abdominal pain in a female with a positive right upper quadrant and a negative pregnancy test, it's a ruptured ovarian cyst,
Right.
which causes a little bit of blood, and they can, they can have significant amount of blood in their abdomen.
Is on this side, is this, so here's the,
This entire
right here. Well, is this anything in particular? Is this?
No, that's just a part in that entire ovarian structure here.
Okay, so
So
it's
it's
not
just a
like a separate
complex,
system. Okay.
complex mass in the ovarian. Okay, so this one is a patient also that has, this is a 25-year-old patient that was drinking heavily last night. She comes in with severe abdominal pain. She was seen the day before with similar complaints, was diagnosed with anxiety, given Ativan and discharged from emergency room. She comes in the next day. She's young, and now the abdomen to the treating provider showed some abdominal distension. So he wanted me just to quick do an ultrasound, see if she has bleeding, ectopic, or something. So she has a positive right upper quadrant, same as the one before, that subtle free fluid. Now I'm looking into a pelvis. So Ryan, can you take, so this is a patient already with a positive sort of sliver of fluid in the right upper quadrant. Now we're going to look down with the probe into the pelvis. So what structures do you see? And
So this is a new pattern?
no, this is no. Look at the footprint is wide, so it's not the endocavitary footprint. It's just up at the abdominal setting, and it's a curvilinear probe 6'2". So it is your typical fast view over the suprapubic area. It's in a transverse orientation. So this is the right adnexa. This is the left adnexa. So the question to you is, what structure? What is this? First of all, so you're looking in the pelvis. What is this?
This is uterus and bladder.
So where's the uterus? Point out the uterus. It's one. This 1 point. That's the uterus right there. Okay, so that's the uterus. So what structure is this?
The bladder.
It's the bladder, yeah. So what structure is this? What is this? What's this? So what sits behind the uterus and the bladder in a female? What?
I can't remember the name. Where it collects free fluid.
Pouch of Douglas, yeah. So this is a significant amount of free fluid in the pelvis. But it can be confusing because you have two structures that look like bladder. So typically, just think about it. The fluid's going to collect in the depending portion, so it's going to be deep into that pelvis. So this is your free fluid with some bowel and rectum floating in that fluid right there. So this is it. And this is how the CT looks of that, right? So this patient actually had hemorrhagic pancreatitis that she had that condition where she just had the inflammatory response and just that fluid. This was actually not blood. This was all just fluid. She was severely, her anxiety yesterday with a heart rate of 140 was all just.
Did she have labs the first time?
Labs, she had a CBC and a basic metabolic panel and Ativan and an EKG of 120. Ativan helped a little bit, so she sent home the previous day. And then she came back, no LFTs, no lipase, and then now she comes in with kind of unstable, still tachycardia, and the Ativan is not helping. So there's the bladder, there's the uterus, and there's the free fluid. You see the correlation, how you could do that correlation. Does that make sense? So that's how a little sliver of fluid in the right upper quadrant area, actually very significant pelvic fluid. That's why the fast examination is sensitive if you're able to do it properly in all the places, not just in one place. Okay.
How come the fluid was layering differently on the CAT scan versus the ultrasound?
Well, the cuts can be different. There's a time delay as well. There's more resuscitation, and the CAT scan, the ultrasound was done on presentation to the EU. The CAT scan is a little later.
Okay.
It's a little different cuts as well. So this is Billy. Yeah.
What was the source of that fluid?
She had hemorrhagic pancreatitis, which causes retroperitoneal fluid, but then she had an inflammatory response to use. So she just sequestrated fluid everywhere. So she was severely dehydrated and she pretty sick lady. Didn't go to Mercy. Okay, so same Billy's patient, meningitis. So Cameron, one of these two images, the patient is successfully intubated. Which one?
One of them, she's successfully intubated.
Which one?
Let's see. On the.
And that's my point exactly, right? So the literature suggests that tracheal ultrasound to confirm tube placement is a useful entity, but as far as you could not defer which one has a probe and knockdown. So I have some difficulty with that, and so I want to teach you a couple of pills just to look out for, because there is some use in this, and we're going to talk a little bit about it. So this is pre-intubation. So you have the trachea here. You have the air that's normally trachea, takes away the ultrasound images totally. Then you have the thyroid tissue coming around and the carotid. After intubation, when the tube is in place, you're actually going to see a little bit more a ring down artifact that occurs from the tube. So now you have the tube in place, and there's a little bit of a ring down artifact. I don't think that's good enough to confirm that the tube is in. What is useful is when you do this dynamically, this is the patient's esophagus sitting right here. You can see the tube is a fairly big structure that sits there. If you tube the patient into the esophagus, you're going to have two tracheas appear, and it's going to look like this. You're going to have a trachea and a trachea. This one is the tube and esophagus, and this is the one with nothing in it. So that's useful. So you can see that second tube that goes in dynamically into the esophagus, and you can immediately recognize it. So knowing a little bit more
Dynamically, you're saying somebody's
as the
holding an
patient is
ultrasound probe.
intubating it, as they're intubating it, I'm looking and I'm keeping.
As who? Somebody else is intubating?
Somebody else is intubating.
Okay,
yeah.
so you need to sit there with the ultrasound probe while somebody else is intubating to do this.
No, well, you can go quickly afterwards and confirm, but it's very nice because as you do it dynamically, you suddenly see the esophagus just open widely with the tube in it.
So you need two physicians to do this, is what you're saying.
In intubating circumstances, there's usually 10 of us.
Here at this hospital?
Yes.
But I mean, this was the patient was already tubed, the tube was secure, so theoretically, if you were single covered, you could do it.
Yes. We're going to talk a little bit about other things too. Yeah.
Where are you holding the probe? And like how
Transversely.
transversely right there?
So right side, left side, thyroid here, so just right over the tube here.
Like linear probe?
Linear probe, yeah. So L10 superficial ocular probe. So this was the same tube that it quickly just batting through intracranial pressure, and as they're intubating, just moving through a little bit. So yeah.
So I guess I'm kind of confused in the fact that so why is the esophagus on the side of the trachea if you're holding it transversely? Like in the bottom picture, it looks like the esophagus off to the side is a.
Well,
if you're holding the probe transversely, how does the esophagus?
So the probe is in this fashion.
Yeah.
Over the tube. So you suspect the esophagus to be posterior.
Yeah.
Well, that's where the most MRI images during intubation also have proven that the esophagus doesn't sit there. So that's why cricoid pressure is now fallen out of favor. The esophagus often is to the left side.
Didn't know that. Okay,
Yeah.
thank you.
But you would see the double tube back here as well. So other things that you can use in lung ultrasound that's very useful. So when you intubate somebody, you want to use ultrasound. What do you think? What things can you use to confirm that the tube is right? We just spoke to this. There's some problems using just a look at the trachea. It's not as clear for me, but you can look and make sure it's not an esophagus. That's good. What other things do you think knowing bedside ultrasound a little bit, and you want to apply something, what would you do? Somebody's intubated, and you want to make sure that they're intubated correctly.
Lung sliding with respiration.
Okay, good. Lung sliding is an excellent choice. You can see normal lung sliding. The little caveat is now that there's some evidence too that even if you go into the right mainstream, the left side will still slide a little bit. So you can't rule out a mainstem intubation just on sliding. But if the lung slides properly, the tube is probably in the correct place. The other thing that you can use, you could just look at the bottoms where you normally look for free fluid, and you have the patient take a bag, just bag him, and if the diaphragm moves down, the tube is inflating the lungs. So if you use all three of those entities, there's some very good evidence that you can quickly use that as a screening tool to, one, confirm that your tube is in place, two, inflating both lungs, and then maybe with some sliding, if there's less sliding on the left side, you're probably too deep on the right side. Okay, is that clear? Okay, let's move on a little bit. This is just an interesting case. We won't talk much about it. There's a patient with a large umbilical area, mass in the umbilical area. It's tender, so the question is, what is it? So when we ultrasounded, there was no actual loops of bowel. It looked to me just like fat. You could see the defect in the abdominal wall area, and you could see a solid area without peristaltic bowel, and that was just verified in the CAT scan. It was just a little bit of fat in the umbilical area that got trapped in there, and so no bowel stuck in there. So just another useful entity. If you have a hernia, you can go see if there's bowel in there. Does it move? Is it stuck? Is it strangulated? You can correlate that. But that's a little. So this patient is interesting. This patient comes into fast track. They have sciatica. They're not responding to conservative measurements. Dr. Schwab is examining the patient. The patient has right-sided sciatica, and Dr. Schwab just says, "Is tender here?" And as he pushes over where the sciatica is, he feels like, "What is this? Is this a mass or something?" So it feels funny there. So I said, "Well, let's just take a peek. What are you feeling? I'm not sure what you're feeling, but let's take a look." So I think we made it full circle here. So what do you just describe what you see? I'm not suspecting. And with that history, what do you think is going on? Something in the buttocks causing sciatica, and based on this image, what do you see?
Okay, so we're looking at the linear probe.
Yep.
I see a heterogeneous mass with some echogenic parts in it.
Correct. So mixed echogenicity, right? Some hyperechoic, some hypoechoic here. There's another little image, some septums even here. So what do you think is this? Do you think this is an infection? What does this look like to you?
Well, it doesn't look like there's necessarily cellulitis because there's not like the dermal fluid that we tend to see.
Correct, yeah.
It could be abscess.
Could be, yeah. So you can kind of squeeze down on it. Abscesses, if you push the probe down, kind of the pus kind of swirls in there. But abscesses don't typically have the septated areas in it as well. And so this is just a very large 10 centimeter mass inside. So based on the fact that when you talk to the patient, and based on the fact that it's causing sciatica symptoms, what do you think now is going on?
Could be like a nerve sheath tumor.
Could be. So what test do you want to do now? What do you think this patient needs in the ER?
Possibly an MRI.
Yeah. So something, a mass that causes neurological symptoms that's concerning, it's invasive, and here's that mass right there, huge, aggressive, malignant tumor with bony invasion sitting on the sciatic nerve, and that's how the diagnosis was made. Very good clinical examination, picked up a mass, and then that was followed through, and obviously not good for the patient. But you can see that what I want you to identify is a large mixed echogenicity area with some septations. Almost looks like that dermoid that the patient or teratoma that the patient had in the right lower adnexa, and that's the same thing, mass at a different place. Okay, it's kind of a cool, interesting case. Okay, so Nick, you're up. So we're going to look at this image first. This is going to be the patient's right lung, and so describe to me what you see.
See some lung rockets and few lines.
Okay, does everybody see these search lights coming all the way from the top part all the way down? You see one dominant searchlight here, okay?
See the lung sliding.
Lung is sliding, so by definition, if you have B lines, you can't have a pneumothorax, right? Because you have fluid originating from two pleural lines. So by definition, B lines rule out a pneumothorax. You don't have a pneumothorax.
Yeah.
So this is a patient, he's 65, he has a history of heart failure, comes with a fever and a cough and shortness of breath. So what he's very short of breath and his BNP is elevated.
Okay.
So what do you
edema versus pneumonia.
Versus pneumonia, okay.
Yeah.
So is this picture that you see, the lung rockets? I want a yes or no. Is this pulmonary edema or not?
It is. Yes.
It's not.
Not.
It's not. Okay. So does everybody see this little thing here?
Yeah.
Okay. Is that normal in lung? No, that's abnormal. That's abnormal. So you see a very classical B line that you do see in pulmonary edema. For the definition of B lines of pulmonary edema, you need 2 or 3 of them that symmetrically placed that go all the way. You see that this one, there's another one there, but it's very smaller and it's not as well placed. For the likelihood of pulmonary edema with B lines, you need it on both sides. That's the other side, same place.
So you have 2 or 3 within the same field of view?
On both sides.
Okay.
To definitely be pulmonary edema. It can still be pulmonary edema, but to absolutely say this B lines of pulmonary edema, you need 2 or 3 B lines coming all the way across, taking all A lines away, and it has to be symmetrical. Okay, so this is not pulmonary edema. So what do you think is what is this typically? If you have unilateral B lines and you have a little schmutz in the lung that look like liver, what is that?
Pneumonia.
Yeah, that's pneumonia right there. Sits right there. So patient with CHF, elevated BNP, ultrasound, no B lines on this side, and corresponds to this area of pneumonia here as well. So I want to just point out that not all B lines are.
Going back to that, you're using not the probe that you typically use for your pneumothorax.
Correct. It's not the linear probe because you want to go all the way down. You want to see the entire lung field. The linear probe is limited to the first couple of centimeters. You want a probe that can penetrate all the way deep down. So that's a very good example of right-sided pneumonia. The probe was just up here in the anterior lung fields on the right and left.
That can move back to the line, kind of.
Or yeah, just above. You don't want to go below the lipid line because then you'll have the confusion of the cardiac structures and the liver dome. Okay, so Liam just lost his second front tooth. That's pretty cute. And Ella in a flapper dress. So the kids are getting big. So this case here is a patient with a fall with significant rib tenderness and a normal chest X-ray. So I'm going to track one rib that she has significantly tenderness to. And I want, who's up next? So I want you to just tell me if you see anything abnormal. Yeah, see that? So entirely normal chest X-ray. You track the rib all the way from the side, and boom, step off. Pretty easy to see. You have to. This skill is actually a little bit more problematic because you have to track that rib with the probe. So you have to have good stability, and the ribs form an oblique angle. So you often have to just track it. But this can be very useful. Also, what if an elderly patient has rib fractures? What are the things that we look for to indicate that they are sicker or that there's something more going on? What's that?
Pulmonary contusion.
Pulmonary contusions, okay, so chest X-ray, and it could be good. What other things you want to rule out? Pneumothorax, yeah, ultrasound's great for that. So you can look for pneumothorax. What other things are you worried about? Subcutaneous hematoma, you'll see that, feel that. What else? Hemothorax, right? So let's look at the same image of this patient here a little bit. So you see the lung back down here. What's in between the rib and the lung? Blood. Yeah. So this patient did fine, didn't need anything, but the ultrasound is very sensitive to pick up fluid, and you can actually see the separation there between the rib and cartilage and the lung there, and there's a little bit of a hematoma there. Okay, perfect. Zach, you're up. So we have a critical patient in, where was this, Ganesh? This is B6 with sepsis. This is the machine, but it's not necessarily where it is. So I think it was B6, the old lady was very septic. It comes in, and what are we looking at here? What do you think that we're looking at?
Is that either an abscess or
Okay, so Ganesh just put a right femoral line in. So just to point out the fact that the guide wire is extremely well seen on ultrasound. Before you dilate the line, you can just see that that wire goes perfectly in the spot that you want it to be. So just a reminder, you did a fantastic job with that line. So that was good. So now saying that, same thing, this is a DVT study. Which groin are we in? Left or right groin? Zach?
It's the whole vein, artery, nerve, empty lymphatics, navel goes, that's the,
What structure is this?
that's the artery.
Yep.
That's the vein.
Okay. So we navigate.
Right?
Yes, perfect. So probe mark is always to the right. So in the right groin, we have the artery, we have the vein. Okay.
Yeah.
So now Dr. Polikoff, I believe, did this excellent study again. So Dr. Polikoff, the server is down, but he just 2 days ago had a fantastic aortic dissection case that we have images. We'll get that to you at some point. But he's one of the cool ultrasonographers in our department. Thanks, Ray, for doing that. Okay, so now, what's going on in this groin?
The vein isn't compressing too well, and it looks like there's some echogenicity right at the bottom aspect right in there. So obviously thinking about of a clot.
Okay, yes or no? Clot, yes or no?
It's what? I would guess and say yes.
Okay, yes, this is probably as obvious as it's going to get. So,
Okay.
because you can
get a trick question, like lead me down that road of.
You meant to say it was
you,
yes,
you don't
absolutely.
always see, and acutely, you're not always going to see that clot, but you're going to see the lack of compressibility. Now, because you don't always see the clot, how do you know that you're applying enough pressure to assess that there's no compressibility?
Like the artery collapse.
Yeah, so you want to put a little more pressure that you start seeing the artery compress a little bit. Most of the time you can fully compress the vein there. And so, yeah, this is as good as it gets. Nice, right femoral clot there.
This is the same patient? Or that was a different
This
patient?
is a different patient, yeah. Yeah, we're done. Okay, so last case just here. So right upper quadrant abdominal pain. So Ryan, right upper quadrant pain, so any abnormalities here. So we're scanning all the way from the neck of the gallbladder all the way to the back. So this is the image I got. And there's two abnormalities that I want you to identify. It was read as null, but there's two abnormalities.
So, okay, so I'm not sure exactly, but I think the gallbladder looks pretty enlarged. Like, I don't know if that's a normal size gallbladder.
Yeah, it is a little enlarged, but it's not exceeding the threshold of 9 by 5, you know, so it's not hydropic, but it's more enlarged, yeah.
Also, this right here, right now, looks kind of weird to me.
Okay.
I'm not sure if that's the CBD maybe, and it looks pretty dilated.
Yeah, that is a great, I'm able to,
But to me, it seems
Make it
like,
stop. Yeah.
in general, though, it seems, I don't know, like, isn't
Yeah,
the
so-
CBD supposed to be down here? And
No, it's going to be right there. The gallbladder usually points to it. So you do see CBD or the portal triad structures. Yes, you have the portal vein, and right at the top of it there's a little structure. They didn't put color on it, but that is a dilated common bile duct there that was not picked up there. And the other thing that they didn't see is the stone right there. See that stone? So if you freeze that image right there, there's a big stone sitting there. It's causing shadow right at the end of the image. And so that stone was missed and the common bile duct was missed.
Is there a little sliver of pericholecystic fluid? There's like one
right there as opposed to it could be. Yeah. So we'll just quickly go through these cases. So time is up. So parasternal long axis view.
Common bile duct diameter, average or normal was.
What is it? What is that? What do you think of that value is? What values do you use?
Is it 5?
I think it's 8.
So it's dynamic, so it depends on age. Typically 3 to 4 millimeters. And how do you measure it? How would you measure that common bile duct?
Is it from outside to outside? Or I'm sorry.
No, it's inner to inner.
Oh, inner.
So yeah, we'll put I think the next one we'll do is we'll maybe play a little game with all the numbers and where to measure it, because it's confusing.
Yeah.
Where do you do a biparietal measurements from outer to inner wall? Aortic measurements are outer to outer. Aortic arch measurements is outer to inner wall. Common bile ducts is inner to inner, and each one has different values. So we'll play with that a little bit.
3 to 4 was, you said?
So that's where you start, and then you add a millimeter for every decade of life.
Okay.
But there is some, it's not exact. There's some people that don't go by it. If you ever had a cholecystectomy, that value can be easily 9, 10 millimeters.
Okay.
So this is a parasternal long axis view. I just want to point out this is a patient, a 35-year-old patient that I had with a new acute dyspnea. You could see that the patient's squeeze is really poor. So new cardiomyopathy, easily diagnosed. And then this is the parasternal short axis view at the mitral valve level. You can see there's really poor squeeze, just to review that a little bit. And then you can go to this Del Mar bird rehab sanctuary. It's pretty cool to take the kids there as well. It costs a couple of bucks to go in, but they take all these abused birds and get them back to health. So any questions about things that we saw today? Okay, great.
Thank you. I'll show you. So, you were doing your blog.
Yeah.
I need to do it.